Good evening, students. I'm yet here with another short note topic from Prosthodontics on resin bonded fixed partial dentures. So it's very important, not just on an academic point or a note, as well as you can make use of the knowledge of how to fabricate and how to diagnose and treatment plan a clinical case for resin bonded FPDs. Okay, so why is it very important? So the need for conservation of natural tooth structure has always been desired, but very elusive role in dentistry, because most of the rehabilitative procedure which we do always has or includes conventional processes which may require the tooth preparation, that to a radical tooth preparation for a full coverage retainer, which is going to be done on the abutments, along with which it is going to support the missing teeth, that is a bonding. But there are other options where you can be more conservative. At the same time, you can produce or you can rehabilitate patient with the required aesthetics. So that is what that option is given by your resin bonded fixed partial dentures. So by definition, resin bonded processes is that is luted to tooth structure, primarily enamel, which has been etched to provide mechanical retention for the resin cement. So as the name suggests, we all know that the processes is basically bonded onto the tooth or the abutments. So how is it done? So we make use of the enamel, which can be etched using your phosphoric acid. At the same time, we can, once the etching is done, the processes can be bonded on to that particular tooth or abutment using your various luting cements, of which the most universally accepted and used cement being your resin cement. So that is something which gives you the maximum flexural strength for the processes. So that is the method that is what actually is being done when you fabricate and deliver a resin bonded processes. So the resin cement is the one which is responsible for bonding of your processes onto the abutment. So the bonding is happening at the enamel interface of the abutment. And we have a lot of different types of bridges. We are not going in detail, in depth about each one of them in the session. Let me take out a few names in that. So we start with Maryland bridges, Russian bridges, Virginia bridges. So these are all various designs which has been introduced to have a processes which can be bonded at the same time more conservative and aesthetically pleasing. So why do we need to have a relook on these things? Because most of the time the patients are not, nowadays you have a situation of a clinically missing a single tooth in the mouth anterior region. So most of the time the ideal or optimal treatment modality includes placement of dental implants. But when we see the cost factor, maybe other factors too, because of the lack of sufficient bone, or maybe some other time constraints, or the amount of the clinician not sure about the result outcome, where it's going to come, or the prognosis of that particular site. So the patient has to be rehabilitated. At the same time, we need to be more conservative in our decision or in the treatment planning. So that is where we have your resin bonded FPDs. At the same time, it is now because of the advancement in our bonding protocols and the bonding agents, the different generations of bonding agents available, and the more recently developed or higher strength luting resin cements available, the failure rates of resin bonded FPDs has been drastically reduced compared to its the predecessors, in probably from the initial innovative ideas which came up with the Russian bridges. When you come and you see the recent ones, the advancement in bonding, the advancement in designing, everything has taken a lot of change, a lot of turn in its technology, in its strength as well. So now we can almost compare your resin bonded FPDs. Failure rates are much lesser, and at the same time feasible option for a rehabilitation. So we start with it. So we had to be thankful to Bhuvanapur, who developed the technique of acid etching of enamel and later Bowen, who developed this GMA composite resins, which can be bonded onto the tooth. So which was a turning point in the history of adhesive dentistry or restorative dentistry. And so let's see the starting of resin bonded FPDs here. It started with the Rochet bridge. So it was introduced by Rochet in 1973. It was a complete innovation. Till then, all the processes were being considered to be conventional. So here what he did was he introduced the use of ring line retainers with funnel-shaped perforations through them to enhance the resin retention. So here you can see those perforations on the wings of the abutments, which is going to have this wing seated on its lingual surface. So these are the missing teeth, which is being attached to those retainers. And these bonding agents, before being placed at the surface, has been treated with a silane coupling agent, which acts as a bridge, which can help to enhance the bonding of your resin cement onto the enamel. Because we don't have any other much of a mechanical retention rather than having those perforations on the wings. So that is the reason why that processes achieves its retention. So we move on to the Maryland bridge. Again, more advancement in its surface modification. So it was introduced by Leviditis and Thompson. So here what we do is we have full coverage of metal. So these better surface area of contact, and the surfaces are basically electrochemically etched. So because of that, so change in the surface tension of those wings or the retainers will have a better surface for bonding along with the resin cement to the enamel surface. And you have your ABHINAV bridge, where the reference surface of the retainer itself provides the retention achieved by something called as loss salt technique. We do have another technique that is using air abrasion with aluminum oxide particles, which creates surfaces which gives a very rough surface, which is suitable for better bonding strength provided by your resin cement. So these are the basic three designs of your resin bonded FPDs, which are having its historic importance. Nowadays, we do have modifications most of the time. Maryland bridges have been practiced in dentistry. We don't do much of Virginia or Rochet bridges. Maryland bridges taken over most of the recent advanced studies has been done on Maryland bridges. And we do have change in material. All these processes were being fabricated with acrylic or composited or facings. Now we have even zirconia copings, which can be designed and CAD-CAM milled. We have our ceramics, all ceramic restorations that can be milled and given in a single visit. And an adhesive bridge can be designed using the help of a chairside economic restoration of aesthetic ceramic, that is CEREC, and it can be delivered. So what are the advantages of resin bonded bridges? Definitely, when you compare to the conventional procedures or compare to the cost or the financial aspects of implants, it has got a reduced cost. And we don't have much of an anesthetic procedure here, since if you're doing a vital tooth preparation, the abutment is vital. We are supposed to we may require to anesthetize the tooth in order to reduce the sensitivity or expose when the dentin tubules or enamel has been reduced. The enamel has been reduced, and supragingival finish lines. No need for better accessibility, minimal tooth preparation. And even if the processes is still large, always you have an option of rebonding the process, the same processes. You may not even design or consider refabricating the processes. We can use the old process and refix them. So where do we use them? What are those clinical indications? So adolescents with single missing teeth, traumatic or congenital missing teeth, caries free abutment teeth, good oral hygiene maintenance is mandatory. Maxillary incisor replacement, the most favorable prognosis, mandibular incisor replacements, periodontal splints. You can use them as periodontal splints, which can be fabricated on the lingual surface of the mobile teeth, which once bonded will act as a single entity and try to reduce the mobility of this abutment. Single posterior tooth replacement up to premolars has been done. There are some modifications available like front bridges from Japan, which can be even considered while replacing molars. So the studies show the survival rate for your conventional FPDs being 96% at 5 years, 74% at around 15 years, according to Progress et al. A 1994 study. Same time, the resin bonded FPD studies show 74% success rate at 4 years. And according to Barak, he was able to see the success rate of 93% at 11 years period. Not sure about all the cases, but still the success rate is almost comparable, clinically comparable to the conventional procedures. So moving on to the tooth preparation, the strength of bonding to prepared and etched enamel is found to be greater than that of the etched enamel, but which is unprepared in nature. That is, you prepare in a tooth, expose the enamel surface, etch it and bond. You have a greater strength of bonding than an unetched or untouched enamel of the tooth. So the preparation should also cover as large the area as possible so that you're not interfering with the patient's aesthetic appearance. At the same time, we utilize the maximum surface of the abutment for better retention of the processes. The cervical margin should always be in the enamel and supragingival. That is another very important thing which we have to keep in mind. Preparation should ensure precise insertion and seating of the framework. A 180-degree wraparound of metal is necessary. So moving on to the bonding steps, the most commonly used or the most universally accepted bondings, luting cement here being a dual cure adhesive resin cement, which can be cured with a light curing unit as well as which sets on its own an autopolymerizing resin, and sandblasting of the processes has to be done if it's a metal framework, acid etching if it is an all ceramic. The surface of the tooth has to be acid etched. If it is ceramic restoration, we have to do a hydrochloric acid etching of the surfaces, rinsing and drying, contamination to be avoided at all costs, preferably under dam. The process of bonding has to be done with a dam isolation. Moving on to the disadvantages here. So anything you do, you're doing a preparation once, you keep a burr on the tooth, definitely that is going to be reversible. And since the adhesive procedure, entire thing is depending on how well the isolation is and how well the bonding is being done. So the longevity of the processes cannot be predicted well. No space correction is possible. We cannot alter the shape because I am not touching the abutments. So whatever space is available, your bonding goes into that space. So no alignment correction, proclination, rotation, tilt, inclination, nothing can be correct. We're not touching this. As I said, it's a more conservative to preparation, and temporization in such case, once you do the preparation, it's quite difficult. So possibly you're doing the preparation, leaving the patient. If we are taking the support of the lab and the work has to come back, we may have to leave the patient without. If you leave the patient without temporary, yes, definitely you expose the enamels and patient will have sensitivity. Not a good idea to do. What are the contraindications? So we do have certain contraindications like extensive caries. The tooth definitely requires an endodontic procedure. Patient was having sensitivity to nickel or any kind of allergy to your base metal alloys. A deep vertical overbite where we have the processes is better to have no contacts, because any contacts will definitely create a stress which can result in a debonding. So preferably no contact. Extensive restoration on abutment teeth is present. Parafunctional habit bruxers, you don't have know what type of forces are going to come, definitely not indicated in such patients. So finally, the rapid development in adhesive technology, that's what holds a promising future for your resin bonded FPDs, is originally developed as an interim restoration. Today, because of its higher success rate and reducing costs, is fast making of the processes. Treatment, or it has become as a treatment alternative for permanent oral rehabilitation. So as I said, because of the advanced generation of bonding agent and the technology of bonding, the newer materials in market, more aesthetic ceramics with better strength available in market, resin bonded processes, and also with the help of chairside CAD/CAM designing machines like CEREC, it is possible to design a process in a single appointment and deliver it to the patient, which is one of the most important highlight of this type of restoration. So with that, we conclude the session on resin bonded processes. For your further reading, I would recommend to read on the lab procedures for fabricating each type of processes, advantages as well as disadvantages for each type of processes, different types of resin bonded FPDs, what are the recent advances in detail for your final examinations. Thank you for your patience. Have a good day.